Okay, so we are recording, and Roseann, we'll let you go ahead and introduce yourself and get
Okay,
started.
Zoe, I have
I'll
one
go mute
question
for
though,
now.
as far as forwarding the slides.
Yeah, can you see the little arrows down at the bottom as a
I
presenter
don't see them. No,
to
I don't see
forward them?
them.
Are you seeing
It's this,
the
the
top?
screen's just a little bit funky for me.
Hmm. Let me
Wait a
let
minute,
me
I'm going to
make
move
you
it
a
to my other
host and see if
screen
that
where
changes
it's
anything.
bigger. Okay, I got it now. I got it on a larger screen, so it's fine.
Okay, perfect.
Okay,
Okay,
hi
so
everybody.
go right
I'm
ahead.
Dr. Roseann Schaaf, and I am a professor at Thomas Jefferson University in Philadelphia, and I've had the honor of working with Zoe and Suzanne on Classy, and also the good fortune to work closely with Zoe to take these ideas of data-driven decision making and operationalize them into Ayres Sensory Integration. In our book, A Clinician's Guide for Using Ayres Sensory Integration to Improve Participation in Children with Autism. And so a lot of the stuff that we're going to talk about today comes from that book and from Zoe and my work together, and also from a research project that we did, one that we finished and one that we're in the middle of, where we are using a lot of these concepts about data-driven decision-making to guide the practice of Ayres SI and to study its effectiveness. I'll get on with it then and let you learn a little bit more about it. I also want to thank all of my colleagues in the Sensory Integration Research Collaborative, which includes Zoe Mayu, Suzanne Smith-Rowley, Sarah Schoen, Diane Parham, Teresa May Benson, Jane Kumar when she was living, as well as others that I'm forgetting right now, who really helped with lots of conversations where we talked about how do we really operationalize Ayres Sensory Integration into a clinical protocol that can be tested and then replicated by other scientists, but also that can have utility for clinical practice. And so it's, through these discussions and interactions and feedback from people that I'll present today has come about. And then the next set of people, Donna Kelly, Joanne Hunt, Regina Friedman, Elke Van Hoedonk, and Patty Fowler, are the therapists who worked with me on the first study where these ideas really popped out from our discussions about how do you operationalize what we're going to be doing in the research, and how do you put it down in a usable way. And then, of course, my university, who has supported me in many, many ways throughout the development of this. So tonight, what we're going to do, hopefully, is you're going to understand the value of evidence and data for occupational therapy practice and research. You're going to learn a systematic approach called data-driven decision-making to guide your clinical reasoning in practice for Ayres Sensory Integration, and make thoughtful decisions about why you're doing which intervention. And I'll just tell you a short little story that part of the reason that data-driven decision-making popped out is that I was doing some teaching online with clinicians who were interested in using or who just were interested in advancing their career and their clinical skills in autism. And I noticed that they were choosing interventions without really doing a thorough assessment or without really using any assessment data that they had to guide their intervention choices. And also, they weren't measuring whether what they were doing was working. And so it became pretty clear to me that it was necessary to guide them in a way of being thoughtful and being evidence-based and utilizing data to guide their clinical decisions. So you'll see that that's a big part of data-driven decision making. So as occupational therapists, I'm not sure if everybody on is occupational therapists, but those of you who are, one of the buzzwords now is our distinct value. And so we are trying to explicate our distinct value, which is to improve health and quality of life by facilitating participation in occupations. And so in order to do that, occupational therapy uses a client-centered approach where we focus on the client in their within the context of their daily life, and we help them to be able to participate more fully. And we use a variety of approaches that are all seated within our core expertise of enabling participation. And so I think that sometimes we have one pitfall in our practice, which is what I just spoke to previously, which is that we focus on a technique rather than a systematic clinical reasoning process that will help the person participate. And so again, as you'll see in data-driven decision making, the very first step is to seat your practice in occupation, to discover what that person wants to do and what the challenges are that they're having to do it. And then deciding how we can use our unique expertise as facilitators of participation to help them achieve that end. And so for children who have difficulty processing and integrating sensation that's impacting their ability to participate in their everyday life, when there's sensory motor factors that might be impacting it, we might turn to the Ayres Sensory Integration approach to help us with that. But always the focus is on helping the child participate in their everyday life. So how do we do that? How do we use data, use evidence to guide our practice? Well, one thing to be that's very important is using theory to guide your practice. And so you'll see that that's a part of data-driven decision making too. And then more recently, using evidence has really come into vogue. And so the conscientious use of current best evidence is what we should be doing in our practice. And I have a little picture over there that shows you the three legs, if you will, of evidence-based practice, which include the evidence that's in the literature, the clinical expertise of the clinician, and then the client, or in this case, the child and their family's perspective and what they want. So we look at these things to help us practice in an evidence-based way. And then another way to use evidence-based practice, or to do evidence-based practice, is to use data. So data helps us get to know our clients and address their heterogeneity. Data helps us individually tailor our intervention to our clients, and data helps us measure outcomes. So again, you'll see that data is a really important part of this data-driven decision-making approach to Ayres Sensory Integration. So just a little digression, if you will, about using data to guide your choices. So we do this in our everyday life. You know, we make choices. Sometimes we make choices based on a hunch, but a more I guess I'll just say data-based way to make decisions is to use data to guide your choices. So here's something that most people can relate to: picking a diet. You know, which diet is right for you? There's lots of diets out there. Here's a couple of them listed. How do you know which diet is right for you? Well, hopefully you evaluate the data. So you might look at the data, you might look at what somebody has published, or the rankings of different datas based on the Nutritional Association, and you'll see that the DASH came out the highest. But is it right for you? Is that approach right for you? Well, you want to look further at the data, and here you can see that you can look at it, which one is best for long-term weight loss, which is the easiest to follow, which has the highest nutritional value, which is best for people with diabetes, and which is best for heart health. So the point here is that you're using the data to match your unique characteristics about what you know about yourself. And this is what we want to do with Ayres Sensory Integration and through the use of data-driven decision making. We want to utilize our theory, get to know our client, and then look at the evidence and data and match it best to that child and family's characteristics. So how do you do that? Well, here's a framework. We call it data-driven decision making, and it provides a framework for reasoning through the Ayres Sensory Integration process with a focus on utilizing data to guide intervention and outcome measurement. And you'll see that it's a series of steps. Let me see if I can get this arrow to work. It's a series of steps that you go through, and we're going to go through each one of them. But one concept that I want to introduce to you now is this idea of identifying and measuring outcomes. And specifically, when we're using data-driven decision-making with Ayres Sensory Integration, we look at both proximal and distal outcome measures. And the proximal outcome measures are the factors that you have identified that are affecting that person or that child's ability to participate in their everyday life. So in Ayres Sensory Integration, it might be poor tactile perception, or poor somatopraxis, or difficulty with vestibular perception and bilateral integration and posture. And you're going to, but you're going to utilize those sensory and motor systems to impact that person's ability to participate in their everyday life. And the participation aspects are the distal outcome measures. They're the ways that the person and the child, the family and the child, are improving their ability to participate in their everyday lives and hopefully their quality of life. So we'll come back to this idea of proximal and distal outcome measurement, but I wanted to introduce it now. So now we'll just go through quickly the steps of data-driven decision making, and then we will do each one separately on a separate slide. So as I said, the very first step in data-driven decision making is seeding it in participation and occupation. And you do this by identifying the child's strengths, and then what are the challenges? Why are they coming to see you as a clinician? What is it that they need and want to be able to do that they're having difficulty with? So right away we start here. And I know this sounds really like, of course that's what we do, you know, but it really isn't. If you take a look at your practice, at least this has been my experience in working with clinicians, we often skip this step and we forget to contextualize it within the child's and family's participation needs. So we'll show you a little bit about how to do that as well. Once you get to know the child, you identify what theory base is going to be used to help guide the rest of your assessment and intervention. And if the child that you're working with seems to have sensory motor difficulties that are impacting their participation, you may want to choose the Ayres Sensory Integration approach. That would be a good choice. And then you would conduct a comprehensive assessment, which would include assessment of the sensory motor factors as well as assessment of the participation challenges and getting a feel for what their current level of function is in each of those areas. And then this is another sort of unique feature of data-driven decision making is you're going to generate a hypothesis. And as you'll see, this generating of the hypothesis really links the assessment data with the participation outcomes. Once you have your hypotheses, you're going to develop goals, and we like to use goal attainment scaling as an outcome measure. So if you're using that, you will scale your goals as well using goal attainment scaling methodology. You'll identify what your outcome measures are going to be, both at the proximal and distal levels. Then you'll set the stage for the intervention, and that includes things like where, the context of the intervention, the dosage of the intervention, etc. You'll conduct the intervention, and we'll talk about conducting the intervention in a way that is replicatable. So following the principles of Ayres Sensory Integration, you can create a replicatable intervention that can be tested to determine if you are meeting the participation goals of the child that you're working with and family. And then finally, after your stated time within the intervention, you will measure your outcomes and monitor your progress and adapt it accordingly. So let's take a look at each one of these steps in a little bit more detail. What we did in our study is we took those data-driven decision-making steps and we put them into a table so that for each child we were able to describe their participation challenges, the assessment data, the hypothesis, the goals, the outcomes, etc. And it provides a template, or a blueprint is really a better word, for your treatment with that child. In other words, what you're going to do and why you're doing it. Okay, so step one is identification of the participation and challenges and strengths. As I said, you're going to seat your practice in occupation, and you're going to ask, what are the reasons that you're seeking occupational therapy? Why is this child seeking your services? Think about what they want and need to do. Ask them what they want and need to do. And a lot of this information you can get by conducting a history and occupational profile record review, watching the child, and talking with the family. And so if the family identifies what the areas of need are, you'll then ask them to describe the current level of the child. How are they doing it now? So something we hear frequently from parents is they don't participate in mealtime because they don't participate in mealtime. And then you ask the parent, well, what happens at mealtime? And they might say, well, you know, he gets up from the table and he goes in the other room and he turns on the TV. Or they might say he plays with the food, he complains about it being too hot, or he complains about that he doesn't like it, and then, you know, he won't eat any of it. So you have to get an idea of what's happening now so that you can understand how to measure whether there's been any progress in how the child does. And again, this sounds like, of course we do that, but I think you'll be surprised that many times we don't get the current level of function and we don't understand what they're doing, especially if we're seeing children in the school and some of their issues are in the home. So a very important step as well. This is a little bit about the occupational profile. We have one in our book, an occupational profile, and there certainly are others available. But here's some of the information that the occupational profile gives us. It tells us the demographics of the child, their age, gender, etc. A little bit about their history, both their medical history and their developmental history, what they like, their favorite activities, what a typical day is like for them, how they do with their daily living activities like dressing and bathing and sleeping and those such things, and then how they do with participation in social and in work or school activities. So I think you can begin to appreciate that the occupational profile will give you a fairly good idea of the child and in the context of their family and in their daily life, and what they were like when they were younger and what they are like now. And this is important information because it's going to help you decide and design your intervention. Once you've gotten to know the child and you've identified their participation challenges, if you feel that their participation challenges are impacted by sensory and motor factors, again, you might choose the Ayres Sensory Integration approach. But if you don't feel the factors are impacted by sensory and motor factors, you might pick another approach in your occupational therapy toolkit to work with this child. So when you identify your theory, you need to think about which theory is best matched to guiding assessment and intervention. And this is a thoughtful, reflective process that's based on the child's needs. It's not based on the therapist expertise. So just because you're trained in sensory integration or another kind of intervention like DIR or etc., you're not going to choose that intervention because of your expertise. You're going to choose your approach, your theory, based on what you feel what best matches the child's needs. Once you've done that, it's time to conduct an assessment. And once again, it's important to think about how to tailor the assessment to the child. What are the kinds of factors and issues that you want to assess for the child? Do you want to assess? Do you feel like you need to assess their sensory motor features? Do you need to assess their ability to do various gross and fine motor skills? Do you need to assess their ability to attend to different areas or their executive functions? So you want to think about what are the areas that you need to assess with this child. And then use standardized assessments whenever possible. Standardized assessments have been developed in a very rigorous way with strong psychometrics. And so it makes sense to use these standardized assessments when possible because they're going to give you the most specific and reliable and valid information about the child in the particular area that you're assessing. So again, the assessment choice is guided by the area of concern, the likely area that you've identified, the occupational therapy scope of practice or domains within your distinct value or unique expertise, the individual considerations, that includes the child and the family, and then the contextual factors. Where are you going to be working with the child? What's the access that you're going to have to that child and family? And all of those are going to impact your assessment. So assessment data is going to differ for different populations and contexts. For children with autism, we may want to identify the client factors that are affecting mealtime or dressing participation, following classroom routines, staying seated at a desk for participation in learning activities. I just picked these because these are things that we hear most often from the families that we're working with. And you want to assess the environmental factors that support or impede their participation in these activities. And you want to assess the social or contextual features that might support or impede participation in these activities. So as a good OT, you want to be able to consider and get data on the client factors, the environmental factors, and the contextual factors. And these will all go into creating your hypotheses and driving your intervention choices. So in the Ayres Sensory Integration approach, we have some assessments that are designed to evaluate the sensory motor factors that might be impacting the child's participation, and these are on the top row here. So we have the SPM, which, as you know, is a parent or teacher report measure that asks mainly about reactivity to sensation, but also assesses social participation and praxis. Similarly, the sensory profile, which is a parent report that focuses mainly on sensory reactivity. And then we have the SIPT, which gives us very good information about sensory perception, praxis, and related motor functions that might be related to the vestibular system or to the other sensory systems. So to do a complete assessment of the sensory motor factors, you will want to use something like the SIPT, which is a performance-based assessment, which allows you to observe the child's performance. And you may also want to supplement that with a parent report measure. But just be aware that if you're only using the SPM or the sensory profile, you're really not getting a full picture of the child's sensory motor issues because they don't assess perception very thoroughly, and they don't assess, and everything that they do assess is based on parent or proxy report rather than direct observation by a skilled clinician and then comparison to a normative sample. So these assessments that are in the top row might be assessments that we use to identify those proximal factors that are impacting participation. And the ones I have on the bottom row are assessments that might tell you about the child's ability to participate in occupations and activities. And so, in fact, in our studies, we use the PD-CAT as an outcome measure to evaluate how much the child changed in their areas of daily life, in daily living activities, socialization, and things of that nature. And as you probably are aware, there is a new test that's being developed. It's called the Evaluation in Ayres Sensory Integration. And this is going to be an updated test with updated norms and hopefully easier to use. I think it will be easier to use and certainly more accessible for us so that we can evaluate all of these factors related to sensory integration. And this example right here is showing you some of the tactile tests where they are evaluating the child's tactile perception and localization. Okay, so now you've done your assessment, and now it's time to analyze your assessment data. Now again, this sounds like it's common sense, but many times clinicians don't really utilize all the data that they have from their assessment to make thoughtful and informed decisions about intervention. So you want to take a look at, if you're using this SPM or the sensory profile, you need to dig down into what's driving those particular scores on the various subtests. So if a child scores in these definite problems range in tactile, what does that mean? Does that mean they have tactile hyperreactivity? Does that mean they have tactile hyporeactivity? Does that mean they have poor tactile discrimination? So you have to take a look at those items, and that's actually what we do with every kid that comes into our study. We take a look at their SPM scores, but then I go down and look at all the items of the SPM to see what's driving those scores. So because I need to know how to help guide the intervention if they're going to be working on a reactivity problem, or if they're going to be working on a perception problem, or if they're going to be working on both, and if they're going to be working on how that impacts function. So it's very important to drill down into the item scores to help you understand the key factors that are impacting this child's function and participation. And then also up here, I talk about triangulation of data. And what that means is taking your data from several sources and seeing what the common themes are. So you want to, again, think about what the parent or the teacher has told you about the child. What have your observations told you? And then what is the standardized assessment data telling you? And then together, you analyze that assessment data and go on to the next step, which is generating hypotheses, which I'll show you in a minute. Now, analysis of assessment data can be facilitated by tools that help you organize and look at the themes that are in your assessment data. And here we've developed the Ayres Sensory Integration Assessment Interpretation Tool to help guide your thinking and reasoning with your assessment data. And the way this tool is organized is that each column is a different sensory system, if you will. So you can see this first column in sort of light purple is vestibular processing. The second column in darker purple is proprioception. The third column is tactile. The fourth column is visual. And then the fifth and sixth columns are related to sensory reactivity, either hypo or hyperreactivity. So on this assessment sheet in total, we have all of the common clusters of problems that might occur within the theory of Ayres sensory integration. And so if you take a look up here at the very top row, you see that it says problems in vestibular and bilateral integration, and that this bar spans across the first two columns, showing that in the factor analytic studies, problems in vestibular and bilateral integration loaded with vestibular and proprioceptive challenges. So these are the things that make up this type, vestibular bilateral integration. And then the next type is problems in somatopraxis, which includes difficulties with tactile perception and difficulties with proprioceptive perception. And when children have this pattern, that's the word I was looking for, pattern, it's a somatopraxis pattern. And then we have problems in visuopraxis, which is associated with difficulty with visual, motor, and visual perception type of things. And then a pattern in sensory reactivity, hyper or hyporeactivity. And then a few more things I want to tell you about this chart is that in each of these cells, it lists the test on the SIPT or the SPM or the Brunick-Ozoretsky that might, or some other commonly used assessments that might fit right under vestibular processing. So for example, you can see here SIPT, post-rotary nystagmus low score would go right here. You would check it, or I turn it red when I'm doing this. A low score on SPM body position and movement would go under vestibular, et cetera, et cetera. And so over here with proprioception, you'll see the SIPT kinesthesia score and the SPM body awareness score. I'll just give you a few more examples. With tactile perception, you would see some of the SIPT tests such as finger identification. With visual perception, some of the SIPT tests such as such as design copying, there it is, and constructional praxis. But I think you can start to see how you can use an interpretation tool like this to plug in other assessment results too. Here you can see the motor free visual perception test. If that's what you're giving and the child scores low there, it might go here in this. And then again, the hyporeactivity in each of the sensory systems on the various tests of either the SPM or the sensory profile, and hyporeactivity. What we've also included here is another area which is called problems in motor-related functions. And so these are areas that you might test or observe that the child has difficulty in, for example, writing and equilibrium reactions, which would load with vestibular functions, or bilateral integration difficulties, which would load with vestibular functions based on the factor analytic studies. An example in proprioception is if they have poor standing and walking balance, perhaps on the SIPT or the Brunick-Ozoretsky, the BOT2, you would load it here, et cetera, and then some common behavioral signs, and then just some notes or caveats, if you will. So when we do our studies, each child gets an SPM, a sensory integration and praxis test, a occupational profile, and then a number of participation outcome measures such as the PD. But what we do with our sensory motor data from the SIPT, the sensory processing measure, is that we fill out this form, and then it tells us where the child's sensory motor difficulties lie. Is it a vestibular bilateral integration problem? Is it a somatopraxis problem? Is it a problem in just one sensory or two sensory system perception? Is it hypo and hyperreactivity, or is it some combination of these? And it really helps to give us a visual picture of what the child's sensory motor difficulties are, and it helps us so much with this. Actually, it guides this next step, which is creating a hypothesis. So now that you have your assessment data, you're going to link your assessment data to the participation challenges. So whatever the participation challenges were, if the child is having difficulty at mealtime, having difficulty with their morning routine, having difficulty with their class, participating in their classwork, you're going to take that assessment data and you're going to link it. You're going to look at the assessment data and say, how is this impacting this participation challenge? So your hypothesis is a predictive statement that links the underlying factors to the participation challenges. And in the case of Ayres Sensory Integration, it's linking the sensory motor factors to the participation challenge. It's based on the interpretation of the assessment data. Now, once you have your hypothesis, you can think about your intervention as being hypothesis testing. What you're doing is creating a hypothesis. For example, Rowan's difficulty with dressing is related to poor tactile perception and somatosensory, wait, I said that wrong, poor tactile perception and somatopraxis. So now you have a hypothesis that this child's dressing issues are related to his unawareness of where his body is from a tactile perspective, and that his test scores indicated a somatopraxis. I hope you can see that once you have this hypothesis, it's going to drive what you do in intervention. In this example that I'm talking about now, you're going to focus on increasing active, individually tailored sensory motor activities that are rich in somatosensory experiences, and that also translate those experiences into praxis by doing various praxis activities that challenge the child's body in new and different ways. Okay, let's take this idea of hypothesis generation a little more apart and take this example of poor somatosensory perception and praxis are affecting the child's ability to arrange and put on clothing independently. So that's a hypothesis for a participation challenge of difficulty dressing for participation in daily activities. And it's a hypothesis where the assessment data has pointed to somatosensory perception and praxis as being the factors that are impacting it. Here's another potential hypothesis when the assessment data does not indicate a sensory or a motor factor. Perhaps it's cognition. Perhaps you've tested the cognition. So that hypothesis would be poor cognition is impacting the child's ability to sequence the steps to arrange and put on clothing independently. I think you can see that the treatment will be different with hypothesis 2 versus hypothesis 1. I think I have one more example. Yeah, short attention span. This would be a different hypothesis, but toward the same participation challenge. So when you're creating your hypotheses, I'm going to go back to that for a minute, it's important to do an assessment and then use your assessment data to create these hypotheses. Tonight, we're focusing on Ayres Sensory Integration and children who have difficulties with the processing and integrating of sensation. But I just wanted to make the point with this slide that the idea of hypothesis generation is about taking the assessment data and translating it or connecting it to their participation challenges. So here's another way to think about this idea of hypothesis generation. Get the participation challenge, identify it, get your assessment data. In this case, we have assessment data that shows poor somatosensory perception and decreased praxis, and then make your hypothesis. Decreased somatopraxis and somatosensory perception are impacting the child's ability to dress. Okay, so I'm just keeping an eye on the time, and I'm gonna move along, but if you have any questions about that really important step of hypothesis generation, hopefully we'll have a little bit of time at the end. Next step is to develop your goals. You want to identify what the goals are for intervention, what your outcome's going to be, and you want to explain or describe them in enough detail that they can be measured. So here's an example. With setup, the child will dress themselves independently within 10 minutes with 2 verbal reminders on 4 out of 7 days per week. Now this can be tested because we'll know the baseline of the child, and we'll know, and then we'll be able to see how they do in set amount of time. Once you have your goals, you want to identify your proximal and distal outcomes. Here's this idea we talked about at the beginning, that the proximal outcomes are the specific factors hypothesized to be affecting the participation or goal attainment. And in the example with the child dressing and the praxis and poor somatosensory perception, we're going to measure whether somatosensory perception changes and whether somatopraxis changes. But more importantly are the distal outcomes, because these are the things that the child and the parent or the teacher really care about. Did the child get any better at dressing? Were they better able to sit and attend in the classroom? Did they participate in mealtime better? So these distal outcomes are very important that we measure them. The proximal outcomes help us link the factors that we're working with in treatment to these distal outcomes and test them as well. So our outcomes. I'm going to just skip over this slide but say that it's a study that we did to identify outcome measures of functional skills for children with autism, and we evaluated a number of distal outcome measures for use in our current clinical trial. And we decided on using the AMPS and the evaluation of social interactions as our distal outcome measures because they came out the strongest in terms of their psychometric properties, and they were the best match for the kinds of outcomes that we wanted to test. So I'll let you just look at that in more detail later. So again, this is just more about proximal and distal outcome measurement strategy. And for an outcome of dressing independently in 10 minutes, the proximal outcome, as I said, would be improvement in somatosensory perception and praxis. Here's some ways that we might test that. We might look at change in SIPT scores or BOT2 scores. And then the distal outcome of dressing, we could use the PD, but we also could do systematic observations of time spent in dressing and the number of prompts and chart them so that we could evaluate the differences. So this idea of outcome measurement allows us to measure the effectiveness of the chosen intervention. The proximal outcomes allow the therapist to validate the hypothesis. Are the factors that were chosen to work on targeting the areas of need? And the distal outcomes allow us to measure the progress made in participation in daily activities. And by using this sort of systematic reasoning process that we just went through with data-driven decision-making up to this point, and creating this hypothesis and testing this hypothesis, it allows you to create evidence through your everyday practice. Once you have, I'm just going to get a drink. Once you have everything set up, you're ready to set up the intervention. So knowing your hypotheses for the case that we're using as an example with the child having difficulty dressing, we're going to design an intervention. It's going to be systematic. It'll be driven by Ayres Sensory Integration theory. It'll be evidence-based because there's now evidence to show that this intervention works. And it'll be replicatable, meaning that you're going to choose and describe your intervention so that it can be replicated by others. In addition, setting the stage for intervention also requires that you think about dosage, setting, and approach. So for dosage, that means how long is the intervention going to be? Well, I don't want to do that yet. The dosage means how long is the intervention going to be in terms of how many weeks. And also you're going to think about how many times per week you might do the intervention, etc. So you use the data and evidence to guide your dosage choices. Now, we don't have a lot of data and evidence about dosage in OT yet. So it's something that you need to pay attention to and think about and be thoughtful of and try to match the child's needs as well. You also want to think about what's the setting going to be. Is it going to be in a school, a home, a community, a clinic? That's going to impact your setting up of the intervention. What's the best approach for you to use, and what's dictated by the context and the situation and the payers? Are you going to be using a school approach, a home approach, and if so, which models are you going to be using in that approach? Again, you should choose the models, all of these things based on the client factors and the client needs. Whoa, didn't mean to do that. Once you have all these things in place, you're ready to conduct the intervention. And when you do the intervention, you want to, again, use evidence-based strategies, use manualized tested protocols, use replicatable interventions as closely as possible, and most importantly, tailor the intervention to the individual. I like to say that Ayres Sensory Integration is individually tailored sensory motor activities contextualized in play at the just right challenge to facilitate adaptive responses and participation and performance in activities. It's a mouthful, but it is. It embodies how we tailor it to the individual, as well as follow the theoretical approach and follow the evidence as well, using the evidence for the approach. And to learn more about the Ayres Sensory Integration approach, I just direct you to our book that not only describes the application of data-driven decision-making directly using Ayres Sensory Integration, and it also has some cases in it. It has all the forms that we talked about, including an occupational profile, a form, the data-driven decision-making tables and forms, the assessment interpretation tool form, etc., so that you can begin to utilize this approach. And then it also has ideas for how to guide and implement your treatment. Once you do your treatment at the dosage that you identified, it's important to do this very last step, which is to measure and display your outcomes. So you can use standardized tests to measure pre and post, provided that they have been validated for use in that way. You can use graphs and charts to show pre and post data or daily or weekly progress. Down here in this chart, this is a chart that shows a child who was having difficulty using the toilet. And you can see in the red line that the use of the toilet went up dramatically over the intervention period. And the soiling in his clothing went down dramatically during the intervention period. So systematic charting like this can be very useful as an outcome measurement tool. So I'm just going to summarize now and then open it up for question that using data-driven decision-making allows you to create evidence through practice. So being very systematic in your approach, using evidence and using data to get assessment data, create hypotheses, and then identifying outcomes that's going to give you additional data after your intervention is a very systematic approach that will help you do this, create evidence through practice. So we're not going to have time to do an example of it for Ayres Sensory Integration, unfortunately, But I will direct you to a couple of resources that you can take a look at, and I'll do this rather quickly. So our one study is published in the literature. It's in the Journal of Autism and Developmental Disorders, and it talks about the intervention that we did and the findings that we had that were very positive about the children who were enrolled in the randomized control trial of Ayres Sensory Integration, 30 one-hour sessions over a 10-week period. Basically, our model was that we did the intervention and we expected an outcome. But here, this is called a mediation and moderation model, and we felt that our hypothesis was that Ayres Sensory Integration was going to mediate the change in outcomes, and that also the moderators such as age, severity of autism, parent investment, socioeconomic status were also going to have an impact. This is a little bit of a simpler graph that shows you how we were thinking about this intervention, that Ayres Sensory Integration was the intervention, and we were going to measure the proximal outcomes, the sensory motor factors, as well as the distal outcomes, the participation-based changes, or the dependent and independent variables. This is the design of the study. You can see right here, I want to call your attention to we randomized after we did a very thorough characterization of the children, phenotypic evaluation, lots of assessment, hypothesis, and goals. We randomized them to either the occupational therapy using Ayres Sensory Integration or to the control group. And in the OTSI, we used the manualized protocol. We did a post-test, and we measured at proximal and distal outcome levels. We used a replicatable manualized protocol, which is described in the book. And we use data-driven decision-making. The manualization of the protocol, is described in this article, which talks about how we manualized the protocol and got information from the therapist and from other stakeholders in order to make it something that would be clinically useful as well as research rigorous. And one of the things about the Ayres Sensory Integration approach and its reproducibility is that it's a complex intervention. And so we chose to exemplify that in cogwheels, which show that there are specific principles and practices to the Ayres Sensory Integration approach. For example, the context, the just right challenge, the therapist-child collaboration, ensuring success, contextualizing in play, but that these are turned differently for each child so that it's individually tailored, but it follows these principles. And similarly, for the sensory motor factors, we address these sensory motor factors, but we address them in a different way for each child. So the idea of taking these principles and tailoring them individually is a pretty complex process that requires sophisticated clinical reasoning and skill to do. One of the things that we did in our study that ensured its rigor is that we measured whether the intervention was adhering to the principles of the Ayres Sensory Integration approach. And fortunately, we have an ASI fidelity measure that has been validated and shown to accurately measure whether the approach fits with, is consistent with the Ayres Sensory Integration approach. And we've published about that as well. And here's one of the articles. You can read more about that as well. And we, prior to doing the larger study, we did a feasibility study to make sure that it was safe, it was acceptable to parents, that the therapists were able to do it with high fidelity, and we found that that was so. And that's also published in the literature and can give you a little bit of insight into some of the issues that we considered when setting up the intervention and then manualizing it for testing. We use these assessment tools to identify the sensory motor factors. We used distal and proximal outcome measures, and our primary distal outcome measure was goal attainment scaling. And then we supplemented that with the PD and another instrument called the PDDBI and the Vineland. So all of these instruments were used to assess distal outcomes, but goal attainment scaling was our primary measure. And then proximal changes, we looked at the changes in sensory motor factors on our sensory assessments. We found that the children that were involved in the occupational therapy using sensory integration scored significantly higher on our primary outcome, which was goal attainment scaling. And you can see over here that we had a very nice p-value, 0.003, and a very strong effect size of 1.2. We also showed, so supporting those goal attainment scaling findings, the PD showed that the caregivers reported that the children in the treatment group, right up here in this column, made statistically significantly greater change in the caregiver assistance that they needed in self-care, and a surprise finding for us was in socialization as well. And so we had good significance here and good effect size as well, very respectable effect size. And then the PDDBI, we were able to show that some of the areas, such as sensory approach behaviors, went down more dramatically in the treatment group, which is a good thing. This instrument, lower score is better. Arousal regulation decreased more dramatically in the treatment group, and ritualisms and resistance to change decreased in the treatment group and stayed flat in the control. Now, these findings were not statistically significant, but they indicate trends in the direction that we hope for. So with this publishing of this study and the other studies that are in the literature, we now have sufficient evidence to say that to support that Ayres Sensory Integration is an evidence-based intervention. It meets several different evidence-based intervention criteria, and we've submitted a paper now that will show that. And this is just saying that it does in fact meet the evidence. And so we've used this now to support the need for 2 more studies. This is one study that we're doing, a very large study that's supported by the National Institute of Health. We're testing whether Ayres Sensory Integration in comparison to a behavioral intervention, discrete trial training, continues to show positive gains in functional skills. And we're also looking to see if the brain's ability to integrate sensation, called multisensory integration, measured by evoke-related potential during EEG, changes as well. And if this is the case, we're going to have evidence that shows not only does Ayres Sensory Integration improve functional skills and performance, but also that there are concordant changes in brain function, suggesting that it supports the theory of Ayres Sensory Integration that we impact neuroplasticity. So time will tell on that one as well. So just to end, I want to say that to emerge as leaders, we must articulate our unique expertise as facilitators of participation, use best practice, embrace a systematic data-driven approach in your practice, which I hope data-driven decision-making will give you an example of which to do. Display and analyze your data, in other words, use data, and create evidence through practice. And it's up to you to continue with this and continue to generate evidence through practice. I think that's it. Yes, okay, I made it with 1 minute to spare.
Mm-hmm. Thanks. Thank you so much, Roseann. You're so eloquent and clear on
Thank you,
such
Zoe.
important information. So, gosh, and
Yeah, I talked a lot.
sounds like you're losing your voice. So, let's open it up for questions. You can go ahead and either type them. I'll make the chat box a little bit bigger so we can see it. But I've given everyone a microphone, and if you would like to speak, you can connect your audio, your microphone, by clicking on the little downward arrow next to the microphone at the top and raising your hand, and then we can recognize you.
Zoe, I see there's a
Hey,
question about the
Danielle.
slides being available. Will they be
Liana.
able, they'll be able to get the entire presentation, right?
They will be able, yes, this session was recorded and we will be sharing a link to the session. So the slides won't be downloadable, but the presentation as it was recorded will be available. And we'll share that link. We'll be able to do that by tomorrow. Okay, does anyone else have a question for Roseann? We hope that most of you can stay on for just a few minutes after the questions. Katie Estrada, our executive director, is going to share a few slides as well. But does anyone in the group have any
Thank you,
questions for
Viviana and
Roseann?
Richard. You're welcome.
Okay, well, you all could keep typing. Roseann, I don't know
Oh,
if
I
you need
can
to
hang around for a little bit.
exit immediately. Um, Okay, so Katie, maybe you could come on and just share the other slides, and that would give the group a chance to type any questions. It doesn't look like anyone's connecting their audio.
Great. Actually, Zoe, you might be best to go through these first slides, just describing our little introduction, if you don't mind.
Sure, sure. Okay, so we wanted to just go over a little bit about the Collaborative for Leadership in Ayres Sensory Integration and our certificate program, and again, also to answer any questions that anyone might have. And just to start, we wanted to talk a little bit about why we started this program. You know, some of us were very fortunate to have the opportunity to work with Dr. Ayres, and we've always been very inspired by her dedication and her clarity of the tools and the kind of study that were needed to adequately serve children and individuals who have problems in sensory integration. And so we tried to model this program after the priorities that she showed us, and that included all of the important points that Roseann made tonight in looking at choosing a theory carefully, completing a comprehensive assessment that will lay the foundation for our intervention planning. And we do worry when we see clinicians jumping into intervention without having a solid foundation of assessment data. So our program, with the advent of so many wonderful tools and technology, we really, when we developed this program, we really put some thought into what kind of content we believed would be best learned at an individual pace where our learners could take as much time as they wanted. Some people like to go through things quickly and then come back and review. Other people take a more slow, methodical approach the first time. So we looked at the content that we wanted to include and we divided that into that content we thought might be best learned online at one's own pace, where review could occur, and then with on-site courses that would feature the content that really required interactive hands-on practice. And so we have 6 modules. Katie, let's see, should I give an overview now, or is there more specifics on each one? Let's see.
There's more specifics on. Yep.
Okay. So in module 1 is sensory integration theory, and we have put this module online. There's a lot of wonderful information on the neuroscience behind Ayres sensory integration, as well as all the core principles. And there's just so much rich information. We'll be adding more videos and other content, and we thought this would be best learned online. We follow that with another online module that we call our online comprehensive assessment in Ayres sensory integration. And this module, we wanted to continue to use the sensory integration and praxis tests so that we had data from normative data information that would lead to the interpretation of scores. But at the same time, we have these new tests coming, the evaluation in Ayres sensory integration, the EASY, and we wanted to include both. And to do that, we really felt that we needed to put it online so it would not be so overwhelming in a in-person format. And that way learners could prioritize the information that was most relevant at the time for them related to the SIPT or the EASY or both. We also include the sensory processing measure and some other assessments as well. I see that we have some questions coming in, Roseann. If you can still stay, we'll come back to the question for you in a minute. And okay, you're going to answer online. That's great. And for Viviana, you have already completed a certificate program that included the sensory integration and praxis tests. We would, if you could be in touch with us by email, and Katie can type in the email address that you could contact us at. If you were interested in also completing our certificate, then we could let you know what we can accept from what you've already completed and so forth. All right. Let me go on here. Okay, and these are the areas that are covered in when we think about a comprehensive assessment, we want to make sure that we're covering those main constructs that Roseann showed you in the assessment tool. I think somebody's mic is open. So I'm just going to see if I can figure out who that is. Katie, I don't know if you could go down the list and see if somebody's mic is open and maybe just put them on mute. But we are trying to help and to be more consistent in thinking about areas that need to be assessed and not so much about a specific test itself. It does look like we will have a variety of assessment tools available to us in the years to come, which will be great so that we'll have some options and choices. We then have our first on-site course, which is a chance to practice. And now that we've been doing this for about a year internationally, we're really excited to see how much more effective the on-site practice time with the tests can be when the learners have had a chance to really think about and digest the details of administration and scoring online. So we are launching our first series in the US this year, and we do have our first Module 3s scheduled. We have 2 in California and 1 in New Jersey coming up. I'm going to look at this question for the coming Module 3s, component of the EASY practice. We do practice some of the EASY tests. We are starting to use some of them. In the EASY, we have included some test items that mirror what many of us have called clinical observations, the kind of qualitative observations that Dr. Ayres developed a long time ago and have been used routinely. So we do now practice those tests and use those items and score them. We don't yet have normative data, but then again, we didn't have normative data for clinical observations either. And we do practice some other tests on the EASY, and that will be more and more as we move forward. We will be collecting normative data on the EASY starting this summer. so that we will be seeing a transition in our training from the SIP to the EASY over the next couple of years. We then have a clinical reasoning course online where we have details that go over some of the psychometric properties of the assessment tools and some of the historical research. Some of it's dense, and so we felt that it was best to provide this online again so that individuals could go at their own pace and review as often as they would like. At this point, we know that the online modules will be available to learners after they complete them for at least a year. And if there's interest in accessing these modules after that, we'll look for a way to do that as well. So, this information that sometimes you hear one time and wish you could go back and review, much of the detailed and dense information will be available to review through the online modules. We then have Module 5, which is an introduction to intervention, and this module includes the training in the Ayres Sensory Integration Fidelity Measure. And so there is a separate certificate or document that you would receive at the end of this module that gives you feedback about how accurate you are in understanding and using the fidelity measure. And we've had such great feedback on the workshops related to the fidelity measure. It was originally developed as a research tool, but we have found that clinicians find it very informative for thinking about their own practices and to helping them to review their own treatment to see if they're keeping all of the important principles in mind. And then we come together for the second on-site course, which is Module 6, a hands-on practice course, where there will be an opportunity to conduct case analysis in small groups, interpretation, and then to move on with treatment demonstration. So this reviews our 6 modules. And what's next? Okay, so Katie, now did you want to jump in?
Great. I just wanted to share the upcoming dates for our U.S. On-site modules. As Zoe mentioned, we'll be offering those courses in 3 different cities in the United States, in Santa Rosa, California, in New Jersey, M3 will be in New Brunswick, and M6 will be in Mountainside, and also in Irvine, California. I just want to also emphasize that if you're planning to attend a Module 3 course, allow enough time so that you can complete the online M2 course. We do ask that everyone complete online M2 before attending an on-site M3. So you just want to give yourself enough time to go through all of those lessons, complete the coursework, and feel comfortable going into Module 3. All of these dates are available on our website, and registration is open for all of the courses. And you can find more information at www.cl-asi.org. Or please feel free to contact me with any questions. I'll go ahead and type my email address in the chat box again, just so that everyone has it. And I'm happy to help with any questions you have about registering or about the locations, anything at all. And we are also excited to announce that we will be doing a new series. We'll be hosting monthly small group discussion sessions for all of the participants that are enrolled in our U.S. online modules. And this is going to be a great opportunity for all of those participants to really deepen their knowledge of the content in those modules, to ask any questions that they may have, and also to interact and engage with the other participants enrolled in those online modules. We will have more information about this coming soon, but we were just very excited about this opportunity. We have Melissa Kay on board to lead those sessions, and it will be a great delight to have her. Oh, and Melissa, I think you are on the call. So we're delighted to have you here, and we're looking forward to those sessions. And we will be announcing those dates coming up soon, but we just wanted to share it with everyone, get everyone excited about that, and let you know it's a great new benefit that we're offering to our online module participants. And with that, I just want to leave our website up here for everyone in case they do have any questions or need any additional information. Please don't hesitate to email me or visit our website for some more information. So with that, Zoe, I'll pass it on to you. And thank you so much, Roseann. That was such a fantastic presentation.
Thanks, Katie. Okay, well, we don't want to keep everyone too late. We know some of you are on the East Coast and it's getting quite late. So if anyone has a last question, let us know. Otherwise, we will be stopping the recording, but we will make the link available on our Facebook page and on our website. Yeah. So thank you, Roseann. That was just a wonderful, wonderful presentation and such important information for everyone. Okay, well, thanks everyone for joining us, and we'll look forward to seeing you, hopefully, at a course somewhere in the world soon. Thanks. Good night. I'm going to stop the recording now.
Good night, Zoe.
Okay, thank you. Good night.